Fabulous. Right. So I think, if I may, I'll start with you, Paula. Maybe the best way to, as I say, that personalisation is kind of what we've always aspired to and tried to do. We try to treat patients as individuals and citizens as individuals. But what is it? What's different now? What are you seeing from your members and your patients in terms of their demand for personalisation, and how is Bupa broadly? How is Bupa responding to that?
Oh, thank you, Vivek. I think we're seeing a huge demand from our members, customers, patients across the world for what they perceive to be a more personalised way of receiving healthcare and health information. So people are looking for much more personalised information on well-being, how to stay healthy. They want that information. They don't want general information. They want information about them, some understanding of their own biology, their own physiology, and therefore what they specifically need to do. They're looking for a very easy interaction with healthcare when they need it. And there is a personalisation aspect to that, because the idea of being able to choose where and when you access healthcare. Do you have to go somewhere? Can you receive it in your own home? Do you have a choice of who you see and how you interact, and so on? And then, of course, as you said, increasingly looking for treatments that are particularly targeted at themselves and their specific condition, even the specific expression of their condition. So not necessarily just, for example, generally breast cancer, but what about my breast cancer, and what do I need? We're seeing that across the world. We're responding to that in a number of ways. So first of all, increasing our ability to interact digitally with customers, in various parts of the world, give them apps on their phone. Even very successfully, we've been able to do that with relatives of residents in aged care, and give them an app that helps them have a better knowledge of what's happening with their loved ones. Increasing the information about them, sharing data. I know we're going to talk about data. And giving them choice, again, through some sort of digital or remote service.
Right. So really, I think you've described several aspects there. One is really extending the concept of health care into the realms of actually flourishing, yes, being well,
yes,
and prevention. You've also talked about sort of personalised service provision, i.e. how you access, and presumably that will have outcome benefits as well, because you're able to interact in a way that's much more convenient for you. Well, I presume, but I guess we need evidence as well. And then the nature of treatment. So we've heard about sort of targeted immunotherapies and this, that, and the other, to kind of really focus in on very particular aspects and biomarker-driven treatments. Maybe let's try and sort of go step by step through those. So I know Cry and Livy. I've used Livy. It's an online platform for. That's how I've used it. But I guess there's more to it than that. And so maybe give us some examples of the kinds of solutions that are out there that are in terms of both prevention and that customer service, that patient service interaction.
Absolutely. So I think when we look at personalisation, it's where is that personalisation happening? At the prevention stage, which is so crucial. All of us are different. Each of us will write about 300 million books in our lifetime of health and well-being data. That is where that personalisation comes in. It's not designed to be as a transactional. It needs to be long-term. It needs to be personalised to that patient. What happens after that? Once they've accessed the care, they need that care, what happens after? And it's navigating the health system. It's joining the dots for that patient in order to access the healthcare that they need. I think healthcare systems are confusing for doctors, let alone patients. So if we can make that journey easier, that personalisation, that journey for the patient, that will lead to a better outcome. And I think to just give you a brief example, we have an obesity program in Sweden, where we take high-risk patients with obesity, we tailor a program to them, and we have made a commitment, a long-term commitment to those patients to deal with it from the beginning to the end, a holistic program with physiotherapists, etc., involved in the care. And that's where that personalisation comes in, better outcomes for the patient at the end.
Thank you. John, can I turn to you now? I mean, I guess as a frontline clinician, as well as I think your background in innovation and in R&D, perhaps, I mean, we can talk about the personalised treatment aspect of this and some of the personalised innovations that are coming down the pipeline and are having impacts. I'm not sure whether you're also involved in sort of digital applications and the role of digital and data-driven applications to kind of focus those treatments and focus those management protocols. So maybe you could address that element of it, the treatment element, because we talked about prevention and customer service provision.
Yeah, so I mean, this has been a journey which has really been going on for a very long time and was accelerated by access to a whole set of new molecular tools that told us much more about what was actually causing the major diseases and how best to attack them. So and genomics, of course, was a key bit of that, but so was biomarkers, and increasingly so is digital information related to patients, because if you bundle all those together, you can get a much better ability to predict who's going to get what diseases. And crucially associated with that, we are now entering an era where we want to diagnose diseases before they become symptomatic. So we want to, as the previous speakers and the previous panel said, we really want to work on prevention of diseases, but also early diagnosis and early intervention of diseases, because at the current system, we wait way too late and we treat people with end-stage disease. So that, I think, is probably the key element of creating much more sustainable healthcare systems. So the push to do that has led to the ability now to increasingly effectively predict which diseases people are at risk of in the population. And there are a variety of tools to do that, a variety of risk coefficients, Q risk, for example, the use of polygenic risk scores, the use of a variety of tools to identify who's at high risk. And then there's also a whole array of new diagnostics that allow you to diagnose diseases before they're symptomatic. So the excitement around circulating tumor DNA, the use of a whole variety of other active risk factors, serum cholesterol, blood pressure, and the likes, will allow us to intervene on these diseases a great deal earlier. And so that whole issue of trying to move precision medicine to precision public health, I think is probably the most important thing that healthcare systems can be doing at the moment, because the other model is going to turn out to be too expensive and not work. Now, having said that, there is, at the other end of the spectrum, there is the personalization literally down to the single individual. And so there's a population health precision bit to this, but there's also the ability to identify people with very precise diseases that can be defined often by genetic changes that are unique to an individual. And there are two really good examples of that. First of all, we all have a set of mutations that are new and unique to us, and they will occasionally cause really profound disability in young children when they're born. These are called de novo mutations. But now that we have a set of genomic tools to treat those kids, it should be possible to develop therapies which are literally designed for one person. Now, that will require change in the regulatory system, the change in the way we manufacture products, but that is going to happen for sure. And there are many hundreds of thousands of people out there who will benefit from that approach. And we have, of course, now gene editing, antisense oligonucleotides, a whole range of tools to do that. And then in the cancer space, you will have read about this in the newspaper. The UK is leading in a number of the big personalized cancer vaccine trials, where you literally take an individual's cancer, you identify the exact genetic fingerprint in that cancer, and you make a vaccine for that person alone, and then you immunize them with that. And the initial data, both from Moderna and BioNTech, these are RNA vaccines because they can be made very quickly, look very exciting indeed. So, we are on one hand doing population-based identification of high-risk groups, and on the other hand, doing precision medicine, personalized medicine at the individual level. So this is definitely moving forward on both fronts and will be very exciting, I think.
Great. I mean that's very exciting, and it clearly is going to have huge impact if we can implement it. But you've also raised there some challenges which I'd like to dig into across this panel, which are the affordability thing, the requirement for investment, not only in the technologies and in developing the technologies, but in the data infrastructure that has to support it across the health system, the regulatory innovations that are required, as you've alluded to, and also the disruptions to our ways of working. And some will be beneficial, I guess, in terms of workforce, because we can do it online, but some will also be quite disruptive to our current conventional pathways of care. I want to just start, Pooja, by asking you about the investment thesis for some of these technologies. So, if you've got a patient number of 1 for a technology, how do you, either you're going to have to make that drug astronomically expensive, but what's the investment thesis for that? Or on the flip side, the other side of it would be the investment thesis for some of these digital tools, which don't necessarily have patentable IP. Reimbursement can sometimes be an issue, and so the commercial model is not clear. So as you're wearing your VC hat, your investor hat, what do we do?
So first, I'd like to comment that everything that John said is on the landscaping list for good health tech investors. That is now where you go in that depends on your passion and experience, and also how much capital you have to invest, because we have investors too. So how fast you go in each direction, whether you go down a preventative early diagnostic route, or you go down, drug discovery and personalizing that, and personalized vaccines, all depends on how much capital overall we're driving into the sector. And that's why we do need to be really joined up. And what I've seen is that where governments and, Innovate UK have really backed, particularly in a market downturn, people to get through this time, it creates a really important bridge to that innovation being retained. And we need that. And we can never, as VC, expect all of it to succeed. So that's the important space. And when somebody said to me, yes, you've got capitalist, someone in the audience said, you've got capitalist in your title. And I said, yeah, and being an NHS worker. For me, it's all about bringing private philanthropic capital together with taxpayers' capital. So that's the basis on which we begin. And all the technologies John's mentioned are kind of really important. I think the jury is out on whether, the massive investors who have started from an agnostic space but drive huge amounts of capital will be able to take this thesis right to the end, or whether it will be sector-specific and investors like myself who will evolve over the next 10 years to bring giant amounts of capital, because that all of those individual technologies are billion-dollar projects and more. If the average drug takes $2 billion to bring to market, when you personalize it, you could be talking about more. Where I think AI has a place is what John was saying around simulation. Right. And can you simulate population groups? Can you simulate data in order to make drug discovery and therapeutics kind of go faster? The bit probably predictably that I'm really passionate about is around personalisation in prevention. So being a general practitioner in the UK, I think we absolutely stripped our capability to do prevention and public health. Yep. That is the thing that we were trained in. We were trained to give you continuity. We were trained to understand your family circumstances. We were trained on situational judgment. That is all personalisation. When a schizophrenic patient comes in front of you, they never, ever present the same, because some will have negative symptoms, some will be chronic, some will have other, and wider determinants of health, the social situation in which people belong. We've always been personalising that. If you only give us 10 minutes once a year to come and give you what you told us you need, you cannot deliver personalisation. And therefore, that's where technology has to play a huge, huge part. And whilst you can't protect the IP in some of the digital technologies, you can support them with how they embed into clinical pathways. So none of this technology, none of this investing we do works if we don't bring, you were alluding to it, all the other parts. How do you train the workforce? How do you make time in the clinical pathway? How do you fund backfill so that clinicians have got capacity to absorb innovation? How do you bring scientists together with clinicians? How do you bring the patient voice into the conversation? And so forth.
Okay. I mean, I think maybe that then I would like to focus a little bit more, seeing as you've all talked about prevention, and that's clearly, and we just had that in the last session as well, that's clearly how we square the circle of affordability in this discussion, is making sure that prevention works a lot better than it's currently working. And that takes investment as well as some of the tools you're describing. So I think it's a question to all of you is what are some specific, I'll ask you in turn, okay, some specific things that you see that you're doing or that you're involved with that are really moving the dial on prevention in a way that's affordable and is really delivering cost effectiveness for you all. So maybe Paula, I'll start.
Sure, absolutely. I'd like a general comment first, if that's okay, because I think I'm very fascinated to hear what Pooja's saying, and I think it brings everything together very, very nicely. We have to work in prevention, but all prevention doesn't have to be technical, digital, high-tech. You know, we do and have done a lot of prevention for many years, and what we haven't done is exactly what Pooja said, is give people the space and time to do some of this stuff. Ideally, you'd want the technology to help free up our clinicians to do what they can do best and take the sort of strain off them, if you like, and give them time. In Bupa, we're doing a number of things, mainly, I have to say, using technology and using digital interaction, using apps and call centres, combining data that our customers give us access to, data that we obtain, clinical data that we obtain when they interact with us, if they come for checkups or come and see a GP or a nurse or even a dentist, together with information that we glean from their wearables. So we tie that together. And that's giving us a lot of information, which we have already successfully used to anticipate events before the patient is even symptomatic, just as John was saying. So we're in the beginning of this, but we are doing it. And what we're finding is that people really want it. The appetite for this is very high, but also the willingness to engage is high, and the impact that this has on people's ability and motivation and behaviour change is high. You know, the more specific information you can give people, and the more specific action you can ask them to take, the more likely it is that they're going to do it. And this, I think, is one of the great benefits of personalisation in prevention and well-being, to engage the individual and have them working in partnership, if you like, with the health provider or the health system.
And then there's lots of things, actually, you both said that I relate to hugely. I mean, also as a primary care physician, the prevention is just so important. I completely recognise 10 minutes every year is just not enough. We are mopping the floor while the tap is still running often. We need to deal with that prevention. And I think the next step is how do we, what tools have we got, particularly as a health tech company? We've got data, 200 million patient interactions throughout Europe. We have got the data there. Using technology, we control through this data to look at patterns, to how often do people access our care, what are they accessing, how difficult do they find it. A lot of our patients are, just under half actually, in medical deserts. So by giving them access to that health tech online, improves access for that population. The second thing is automation. I think you picked up how do we increase efficiency to allow clinicians to do what they do best. 50% of a clinician's time is admin. That can be automated. And that's where we are at the moment. And by introducing that automation in our systems, we've increased efficiency by 20%. Now, that is 20% more patient interaction, that place where the clinician knows best. And I think even with automation, clinicians should always be in the driving seat. Yeah. They always should be. I think quality healthcare is a mixture of that human touch, but also the technology. But that's where we can really help. And I think finally, we need that proactivity. It's useless having all this data, all this automation in order to prevent things if we are not proactive after it. We've got to deal with it at the prevention stage. That's how we're going to prevent cost further on downstream.
John, I mean, do you have any comments on this, on specific examples of where we're improving prevention, or in fact, you raised early diagnosis as well, which...
Yeah. So I think it's really important to think of the prevention agenda as part of a system which identifies people who are at high risk of particular diseases, intervenes probably with largely behavioral interventions, helps people do things that make the disease onset delayed or may even eliminate the disease, but also mix that up with early diagnosis. So almost all the major chronic diseases, if you can diagnose them before people are symptomatic and treat them before they're symptomatic, you can have a massive effect on morbidity and mortality. And so, and what we also know is that if you treat early in asymptomatic people or in very early stage disease, the efficacy of therapies goes way up. So there's some very good work now on immunotherapies in cancer. If the further upstream you move those immunotherapies, the bigger the efficacy. So we'll find that the impact of what we do is just going to get better and better as we move the whole health system to the left, as it were. Because at the moment, we're way down at the right. We treat people in the last 3 months of life. It costs a fortune, doesn't really do much good. Now we've got to shift it all to the left. And I think the other speakers have rightly identified the need to embed that in some kind of information digital system, because managing that on an individual basis is going to be quite complicated. But there are good examples already. So cardiovascular disease is a good example of where we've started to intervene early. And we've also been pretty good at identifying risk factors that can be treated and modify the risk of disease. What we're not very good is healthcare screening. So I think Raggy Valley is talking later today about our future health, but we've got this experiment in the UK where we're looking to collect 5 million people. And we're doing a health screen at the beginning. And what we found is that about 50% of all the adults we look at have cholesterols in a range that they should have been treated. Well, that's 1 in 2. Actually, that's not a great result, is it? You think, oh boy. And about 25% have uncontrolled hypertension. So some of this stuff is not very glitzy and it's not very sexy, but boy, let me tell you, it's basic, fundamental. Let's screen patients, let's work out what their risk factors are, let's treat the risk factors and try and flatten the curve of disease. And of course, there's a great deal of excitement now about obesity, partly because we do have tools now to address obesity, which are therapeutic tools, and these drugs really do work. But again, this is a good example of a holistic system, because you can't just bang people with shots of Wegovy and expect it all to sort itself out. So you have to build that into a system where you're managing people's obesity probably over a lifetime. But at the moment, the UK's 26% of the adult population are BMI more than 30, which is obese. So if you're talking about prevention, there's not a bad place to start, because that's associated with all kinds of diseases, mental health, diabetes, cardiovascular disease, most of the common cancers. I mean, it's a massive risk factor. And what's been amazing is the NHS has done nothing about that for decades. And I think we do need to get a grip of that. But those are all examples of things that are ongoing.
Great. Pooja, I mean, please feel free to give examples if you want, but I actually want, working as a GP in the front line, I think so many of these things, they sound so brilliant and so promising. I just want to explore what it actually, it's really quite disruptive, because as healthcare professionals, we tend to be trained or end up per force of just our working lives, treating people at that 11th hour. Our systems are not set up. Even the things you talk about, John, with early diagnosis, some of the biomarkers. I mean, our systems are not set up to do, say, circulating tumor DNA at an early stage. And also, these are dynamic interventions that are, especially the digital things, are changing. The algorithms are changing, and our health technology assessment systems and our kind of way of appraising those for effectiveness aren't really designed for that kind of intervention. So there's so much we could talk about in terms of So, Pooja, let me ask you first of all, address any of those if you like, and feel free to give examples as well. But address any of those, and how do we get round that and change our system to be the kind of system we're describing?
I mean, I think some of it comes down to people being in the same room and collaborating on trust. And we just don't have that right now. We do not have the scientists, the academics and the investors and the clinicians sitting in a single room and creating that trust. I totally agree with John and all the work that's being done with our future strategy. And there's so much great discussion that's going to happen today on the genomics topics. I won't steal any thunder, but we've got some blunt tools that we haven't maximised, as John is saying. So, you know, QRISK-2, which is the cardiovascular tool at a population level to bring people onto statins and use that opportunity to bring weight down and deal with your hypertension, which would massively reduce morbidity and mortality, have an economic benefit, is not maximised. And statins, you know, have become controversial when at a population level they kind of work. And semaglutide is showing that it could work at a population level. We can go upstream. But then when you get down and you start to democratise, which is, I hope, where all the omics work will go, and you combine that information together, then you start to personalise in a kind of very different way, and you reduce the cost curve. Because using polygenic risk scoring and other elements, you can immediately identify a different model of care. You don't need to throw that into the mix of the NHS that isn't currently stable. You can provide a different way of doing it and a lower cost way of doing it. And these are all, as you say, behavioural, straightforward prescribing elements. It's just getting the diagnosis and understanding how to put the money into the highest risk people. Costs a bit of money down that end, but that's technology dependent there. So there's a lot of work to do, but some of it is just sharpening what we know already with some new innovation that's kind of coming together. From an investment standpoint, I would say as though the art of this is going to be who is going to bring all of that data together in a single kind of place. So if you take QRISK-3, which is the next stage, the next algorithm, and all of these algorithms are kind of blunt. So what we want is AI building the algorithm for you on this particular day and independent of that human manual process. QRISK-3 relies on longitudinal blood pressure change. Now, we don't have that in the GP data set. And what I would also argue to my colleagues is that you're now putting data into other systems. So how are we going to join that clinical data? But actually, if you put sensors on people, then you can have longitudinal blood pressure data. So it's who is going to bring these data sets together in a stable kind of way. And, you know, one would argue, how comes big tech hasn't thought this through already? And why hasn't it done it already? Because the innovation is starting to come through. But it's joining sensors, biomarkers, omics, clinical data, digital imaging biomarkers. Who's going to bring all of this together? And that's the investment thesis I'm most excited about, but I think we're a little bit away from that.
But doesn't that demand, well, in this country, it demands the NHS and the Department of Health to be willing to reimburse this sort of activity and to be able to pay for it. And that is quite a mindset shift from a system that has been designed to deal with disease rather than deal with what you're talking about. I mean, maybe. I mean, please feel free to comment, and then I want to ask, get some questions from the floor. I mean, you obviously have contracts with the NHS. You deal with the NHS.
Yep.
How does that? I mean, presumably there have been challenges.
Absolutely, there are challenges, but we do the best that we can with what we've got. And I think going back to your question is who's going to bring that together, and we're starting it. I mean, there's lots more work that we can do, but we've started it with that obesity program on a population, dealing with those high-risk patients, taking them through, not just, I think, as John mentioned, the pharmaceuticals, but actually that joined-up care afterwards, the holistic nature, giving them access to all those professionals in a joined-up way, joining the dots for that patient afterwards. And that's the personalisation bit. That's where it's going to make an effect. But we need that population-level data that to identify who those are. And that's the data that we have with those 200 million interactions in Europe.
And Paula, I mean,
I think the sort of combination of data sets is a real conundrum, and it's something that we have to address. Certainly we see it differently in different parts of the world. So some of our businesses in other parts of the world have much less challenge in this. And the example that's in my mind is Poland, where we have a national electronic record. The government mandates there's a certain minimum data set. Everyone's data goes in there. And that means that a patient moving across systems from a public to a private sector back and forth, their data is there in one seamless sort of record. it requires willingness of the different parties to come together and to share. And we also, of course, when we're talking about this data, when you get to a personal level, we have to have the trust of our patients to make sure that they understand what's happening with their data, happy where it's going, and what we're doing with it.
But maybe you have it, maybe slightly because they've chosen you, and
Yes.
so maybe it breaks that.
But we need to be really careful then who we share it with. You know,
Yes.
we would very much love to have a single patient record in the UK. We'd be delighted to participate in that.
Right.
We'd need to make sure, as I say, that our customers are very happy for that to happen.
Right.
In addition, of course, the NHS and the government has to also be happy for that to happen.
John, you wanted to come in?
Yeah, so I think there are two really central things to make this new model of healthcare work. One is quite rightly this issue of the data. And, you know, the reality is that although we've got large pools of data, it's not hooked up in the UK. And I think that's point's been made. And it's a real problem. And as you remember, during COVID, they introduced a COPI notice, which you can use for public health crises, in which case all the data was then interoperable between different data sets in the NHS. And suddenly the UK became the best place in the world to measure all the things you wanted to measure in COVID. We had better data on vaccines, on testing, on outcomes, on population epidemiology. It was all there. And so it shows what you could do if you actually hooked it all up. And I think the failure to do that is essentially a political failure, because somebody needs to step up and say, this is a public health issue and we need data to do public health. And as a result, we need what is the equivalent of another COPI notice. And just to remind everybody, we had a COPI notice in place for 2 years during the pandemic, and the sky did not fall, as many people said it would. And, you know, there weren't data leaks and there weren't problems with people's data, and it saved a lot of lives. So that's point number one. The second point, if I may just add another thing, and that is this issue of what's the workforce you need to implement a precision public health personalization strategy at a public health level. And the answer is that looks pretty different than our workforce at the moment. And I think one of the things that is really clear is there are bits of the healthcare system, and I think particularly primary care, that is under unbelievable pressure. And I know everybody likes to criticize the fact they can't get an appointment at primary care, but the truth is that's because they're not working hard. They're working unbelievably hard. And I don't see, if you look at the trajectories on the number of people retiring in primary care and the number of people we're likely to draw in, that's not going to get any better anytime soon. So I think we do need, and the second thing is that this does need to be community-based. Hospitals don't do this. This is community-based stuff. And if it's not going to be primary care who's able to do, I mean, ideally it would be primary care, but I think that's unrealistic. You do need community-based functions that can provide this holistic set of care, which is behavioral change, plus injectable interventions, probably adult vaccines, probably the long-acting injectables to prevent cardiovascular disease, obesity, and the likes. And, you know, as we found out in COVID, you could put that in a tent in a parking lot if you have the digital system to run it. So, and you don't need a lot of doctors. So, you know, there are ways to make this really cost-effective, but you have to change the fundamentals. And that, of course, will not be straightforward.
Perfect, thank you. Any questions? Yeah, oh, wow. Okay, we've only got 5. Okay, we'll do what we can. Who went up first? I think it might have been you, yes. Okay, down here. I'll have to take it in order.
Sorry, I'm absolutely desperate to speak on this. So pleased we are talking about prevention, but I'm highly frustrated about how we get that shift, as John is saying, and financially from the right to the left. So sorry, my name's Michelle Salter. I'm the chair of the Sickle Cell Society. Sickle cell, really unpredictable. We know who they are. They can be frequent flyers, blood transfusions, drugs, no obvious cure. We had a pilot which was funded by the NHS in a high prevalence area in North London. So we had a community support worker, so funding for one individual. So they were doing that holistic thing around reducing stress levels, advice on diet. helping with housing, helping with finances, education, employment. It was proven to work in terms of stopping people going into hospital and paid for itself. The funding stopped at the end of the pilot because we were told we were getting involved in matters which were not health related. So we had to let the person go. Ideally, what should have happened was that pilot continued in that part of North London. That expertise enabled us to roll it out within London. We're a national charity. We could have rolled it out to the UK and beyond. So if anyone in the room has got any ideas how we can actually shift resources so that successful pilots in the third sector, which are proven to be successful, can be funded and continue, please talk to me, Michelle Salter.
Okay, well, so that we've got time, I think we'll take that as a comment and then take some more questions, and then this gentleman, then this gentleman, and hopefully we'll get through them all.
Well, thank you. I'll make this really quick, I promise.
Oh, sorry. That one first. It's okay.
The connecting of the dots, this is obviously coming, and there's nothing that's going to stop this. We have more and more inputs, more and more diagnostics that are purchased by people. So what I'd love to know is, how much of this do you think can be driven by consumers? You know, I look at Zoe, where there's an immediate impact for people. They're doing stool samples. We're paying for diagnostics, so we get a direct value, right? How much of this can be driven by the purchasing public rather than the government or by the NHS?
Okay. Can I take the other question as well, and then we'll just try and handle them?
My question's actually directly linked to that in a way.
Okay, good.
That, in terms of genomic data, so I used to work at the genomics unit at NHS England, and a big issue we had was direct-to-consumer testing.
Right.
People coming saying, I have had my whole genome sequence, can I use that data? The issue for us was we had to say no, because we couldn't validate the quality of the testing, the basis of it. So it's that collision between direct-to-consumer testing and when it collides with healthcare, and how you monitor that.
Yeah, okay. So we have a top-down sort of system in healthcare, and then when people go, as they inevitably do, round it, what happens? And also that links to this consumer, that it's being driven by consumers. So I guess we'll have to be quick, but any thoughts and comments on those two questions? Yeah, Pooja, yeah?
Yeah, I'm 100% behind consumers who are our patients now driving the change. And I think there's a fundamental shift, and I think social media and democratizing opinion has a huge part to do with that. So the jury will be out on whether Zoe can actually change clinical outcomes, because some of it is a bit narrow. But by putting the celebrity onto the Instagram telling you should do this, it is working. Everybody knows. And that's where I think, you know, the David Beckhams of the world may influence how we shape healthcare if we get those conversations absolutely right. And I realise that's a controversial thing to say, but the power of influence on the public and using some of that to create better public health intervention and using the tools that are working in other industries is going to be a really important way to get people to shift to the left.
Okay. John's got his hand up then. Maybe you would like both to come in. Yeah, John?
Yeah, so I think this is it's a really important issue, and it really relates to who's going to drive this agenda forward. And as I said earlier, I think it's really hard to do that entirely within the healthcare system. It's asking too much of a healthcare system that's already really overstretched. But there are lots of potential beneficiaries of having a fitter, healthier population and intervening early and preventing earlier. And that includes, of course, the people themselves, but also industry, employers. They all have a real interest in keeping their workforce fit and healthy. And of course, the benefits are not just to the NHS. So we kind of got ourselves in a bit of a rut by saying, well, the way we evaluate whether it's worth paying for an intervention is whether it benefits the NHS, the cost of the NHS. Well, actually, that's not really where a lot of the impact will come. The impact of managing obesity, managing mental health, managing these kind of chronic conditions, that will be economic growth, not the NHS. NHS will help, it'll help them a bit, but it will help the rest of the economy enormously. And as a result, I think we have to look much wider for who's going to commit to helping that happen. And it will also have to involve the consumer themselves. And my personal view is if somebody gets their genome sequenced, it's their genome. They're entitled to that data.
Yeah.
Now, what you do with it is another question. But, I don't think we can be paternalistic and say, oh, sorry, we can't show you your own genetic data when it's their genome. It's not our genome. So, that gets a bit complicated.
Okay, thanks, John. That timer is wagging its finger at us, so if we can be really quick. Bryony, and then Paula, and then we'll have to move on.
Yeah, I think very, very swiftly, I think just to conclude, I think certainly personalisation, I think, needs to be at the centre of a new era of healthcare. There will be challenges. There are challenges. We need to overcome those with time, with collaboration, partnering with people who feel similar sort of ways. But I think that is where we're going to get dividends, not just for the patient, but for clinicians and for the system.
Paula?
I think the popularity of a lot of these direct-to-consumer tests is clear that there's customer and patient demand for this, and I think we need to be cognizant of and responsive to that pressure. My concern is that these things need to be joined up. So my data that sits in Zoe versus my genome versus whatever else, we have to bring these things together, and we have to help provide an opportunity for that to happen.
Great, thank you. Really grateful for this session. I really like the fact that we got onto prevention and the idea of a data-driven prevention for population health, which is clearly the answer to the sustainability of our health systems ultimately, and the tools that we have available. And what we need is political pressure from all of us. So let's leave this room waving that flag for our governments and our insurers and our employers. So thank you very much.
Thank you.
Thank you.